think we'll get started. So welcome everyone. This is our, I'm going to guess it's like our 22nd, 21st, 23rd MedStaff Forum. So thank you all for joining us. And of course, thank you to our expert panelists for being here with us. I'm just going to go around table and ask everybody to just introduce themselves and then we'll move forward. First on my screen is Patty.
Oh, I can't see myself to unmute.
Yeah, you're unmuted. I can hear you.
Oh, I'm unmuted. Oh, good. Hi, Patty Daly. I'm the Chief Medical Health Officer, Vancouver Coastal Health. Nice to be here again.
Thanks, Patty. Sorry, I should have. I'm looking at my screen. I should just be looking at the list that it's ordered. So, Ross.
Hi, good afternoon, everyone. Ross Brown, VP Pandemic.
And Manesh.
Manish Sadarangani. I'm PID physician at BC Children's and director of the Vaccine Evaluation Centre.
Thank you. And I'm Chad Kim Singh and Merch Doc at VGH and Associate VP Medicine Quality and Safety. Titus.
Hi, I'm Titus Wong, MedMicro and Regional Medical Director for Infection Prevention Control here at Coastal.
Great, thank you. And as we begin, I wanted to make sure that we do have our acknowledgement of the land that we are conducting our business and in which we work, live, and play. And for most of us, or many of us, it is the traditional territories of the Musqueam, Squamish, and Tsleil-Waututh people. And to be able to work and play and live on these lands, we are grateful, very, very grateful. A reminder to everybody that this webinar is recorded and it's archived online on the intranet. So only the panelists are recorded, so you don't have to worry about yourself being recorded. Another reminder for our medical staff intranet site, which you will have to have your VCH login. But again, you do it once, you can bookmark it on your phones. If they do face recognition, you can set it to recognize and you don't ever have to remote access in. The announcement section has a lot of great updates that are done many times a week. Another really informative section of the intranet is the vaccine section. So the link that you see there will get you directly to the vaccine updates. I wanted to recognize our MedStaff editorial board. We did have a MedStaff, an emerge doc from Coastal join our group, so Simon Palfrey, to round out. So we have all communities of care represented now. We have representation from our midwives, from NPs, our physicians, and the makeup is as you see there. And you will see towards the end of September, there will be a MedStaff e-newsletter that comes out, and this is curated in part by your editorial board for topics that are important for you to know about and that you fed back to us. A reminder, because of course, as we all join here at what's 5:35 on a, I don't even know what date it is. I think it's Wednesday afternoon. That a lot of us are tired. We're doing our jobs continuously. We have lots of stress in all of our lives and so forth. So I want to remind people that if you need help, reach out for help, connect with colleagues, email, text me. But you also have resources here in the Physician Health Program and VCH EFAP. And so the links are listed there, but there's help if you need it. And I encourage you to please connect if you need to. A reminder that the Docs of BC annual survey is out now. You will have seen it in your inboxes. Remember to go, I think sometimes it ends up in people's junk box or what have you, but it will likely go to whatever email you have listed with the Docs of BC. We were happy and fortunate last year to be #1 in the province of BCH for the responses, both in number, but also the content and how we're doing with physician engagement at Vancouver Coastal. And so we're looking forward to this year, what results we have here. So I do encourage you to take the survey and give us your feedback, because it'll help continue the working relationship that we've been able to build over time, but certainly during the pandemic. So thanks for your participation. Next slide. And a reminder that September 30th, which is a Thursday, is our newly recognized National Day for Truth and Reconciliation. It is a statutory holiday. And for those of you who are going to be working, thank you for working on this day and continue to help in our healthcare system. And for those who do have the day off, we do ask that you think about and think how you can advance and promote reconciliation and for our past, and as we look to heal as we go forward. One thing I forgot to note, there is, you will see in the chat box, I think, a link for the Provincial Health Technology Assessment Committee. And this is sponsored by Patty as the executive sponsor. And you'll have seen it in years past, but it's to help actually highlight and identify health technologies that we think are going to be very important going forward. You'll see more information on this and in the newsletter that comes out at the end of September. But the deadline will be somewhere towards the end of November. So there is time, but it'll be to help highlight and perhaps promote and fast track some technologies. And one of our last slides before we get to our agenda is congratulations to our cohort 5 for PLQI within VCH and Providence. There's a big list here of talented individuals that want to improve their QI prowess and get some projects off the ground. So thank you. We look forward to some of the projects you'll be bringing forward and perhaps spreading and scaling across our organization. So our agenda for tonight looks like this. We are continuing on a theme of building back better. As you'll recall, sometime during the summer, we identified that this is something that we wanted to make sure that everybody was aware of and on top of. And of course, we're in wave 4 now, so it's not only building back better, it's still responding as we are. We'll talk about vaccine effectiveness, and we're lucky to have Manish here again to talk to us about some of the latest evidence. We have some questions that you sent in to us that we'll get to and answer, and then there'll be a live Q&A section. Reminder that to use your Q&A box to put any questions you have as we go through this this MedStaff forum. We won't be looking at the chat box for your questions. It's got to be in the Q&A. So thanks in advance for doing that. So we have some questions that you sent in ahead of time, and we have our panel here to help answer some of the questions.
Okay, I'll just read out all the questions here. We've got, will screeners at hospital entrances be continued to be used? And I'm concerned about the safety of full waiting rooms. What are the plans to improve access to the VCH emergency department, critical care, and procedures going forward? We aren't allowing unvaccinated people into restaurants, but they're still allowed to visit patients in acute care. Is this true? If so, what are the risks? And finally, what are the plans for ongoing support of virtual appointments at VCH?
Thanks, Lori. Does anyone tackle the first one about hospital screeners?
Well, let me kick that one off. I can do a quick one easy. And this was a discussion that has happened at the VP pandemic level for quite a long time because, of course, there's interest. Is it going to happen? The bottom line is when the new rules and orders around long-term care and visitation and changes in the IPAC recommendation we're going to hear about. The bottom line was that the ministry was quite content, really based on feedback from the hospitals, that they do want the screening to continue at the hospital entrances. Obviously, the challenge will be at each site, what does that actually look like? So there'll be some variability, but that principle is the same, so that the common practices of visitation and getting to support families, patients, and so on will continue.
I think that I think the general message, to echo what Ross said, is to continue vigilance, to be aware as staff about our own health, and making sure that if we're not feeling well, or to go and get tested and stay away from work unless instructed to come back by our occupational health or public health colleagues. The other part is that you have to have continued vigilance of our visitors as well, to ensure that, and it kind of has a good segue into that third question, to ensure that visitors who are coming in, that they visit safely. And part of that is ensuring that we screen them and ensure that they are not exhibiting signs and symptoms of COVID.
Thanks, Ross. Titus. Perhaps I'll start for the second question, which is about the safety of full waiting rooms and emerges and critical care areas. I mean, as you can tell, when you work in our sites, we are busy. Our hospitals are running, and as you know, as you see it and feel it, and so at some of the access points, of course, being the Emerge, the waiting rooms are getting busy. We are seeing volumes as we were pre-pandemic, and there's a lot of sick people coming in, and a lot of the people that are needing reassurance as well. And so wait room management is certainly important. And yet at the same time, I think we are better at this. We have a good IPAC measures in place. And those are obviously on our websites on the intranet as well for current ones. And they apply to, of course, our acute settings, our ambulatory settings, community settings as well have information for how to best set up waiting rooms, offices. But in the emerges as well, what some are doing is using what's called a Waitwell app, which essentially allows a person that's could maybe wait, very close, but maybe, out in the ambulance, I shouldn't say that's more the acute side, but say out in a safe area, a bit distance to wait, and they'll be texted when it's their turn. Of course, those patients are appropriately screened and picked for who's suitable to be able to do that. But there are things being done to ensure that the waiting rooms are safe places still. And of course, more and more our patients waiting team have been vaccinated. So that's also reassuring. As far as access to the emerging critical care, I guess that's a very complex question. I'll perhaps look to any of the other panelists to offer any input. But I would say that certainly if we're looking at the pressures, it's a continual balance, right? We know that our critical care areas, our ICUs are busy. We know we've had to change some of our OR slates and adjust as we need to for the demand and some of the resourcing and HR challenges. But all to say that there's still, I think, a lot of access, and that sometimes is what we're struggling with, is that the Emerge continues to be a 24/7 access point. Our urgent primary care centers are access points for in-person care. So it is an ongoing challenge and balance. So I don't have a silver bullet answer for that, but I would try to reassure you by saying that this is certainly something that is being discussed at every COC, every site, every day to deal with the volumes. Any other inputs from our panelists?
Just maybe a comment, Chad, about the waiting rooms. It's not just in the Emerge, but physician offices. First of all, I think you made a good point that it's important that people can access care they need, and emergency departments are for people who really need to get health care. One of the concerns with some of the public health measures we put in place early in the pandemic, specifically the physically distancing, is it did limit access to health care. Some doctors shut down their offices because they felt their waiting rooms were not conducive to this. There was concern about emergency departments. But what we realize now, now we're dealing with a population that's a significant number of people are vaccinated, a much lower risk of infection. We're putting masks on everybody who comes into the waiting room based on the IPAD guidance. You do not need to physically distance. We actually never saw transmission occurring in our emergency department waiting rooms, even before we had robustly vaccinated people with the IPAD guidance in place. So some of you, hopefully all of you have seen the letter that's come out from the ministry about doctors resuming in-person care. And we hope that the new guidance, and Titus can talk to this, which removes the need to physically distance in waiting rooms, because we know that that's not necessarily to keep us safe and to keep our patients safe, will allow people to feel more comfortable now, not just in the emergency departments, but in their offices and seeing patients. So I don't know if you want to comment on that, Titus.
Yeah, no, absolutely. I completely agree. We are in a different space than we were a year ago, due to the very hard work of public health and others to promote the vaccination campaign. And when the physical distancing measures were put into place, public health along with several others, it was during the time where we didn't know as much. We didn't have a vaccine. It was an abundance of caution. I think it was appropriate at the time. And now that we're in a different space, we have to really get back to exactly what the bolded word is on the screen: improving access and getting back into providing the care that our clients and patients need. We hadn't used that previously, physical distancing as a measure, and so now we're going back to using our traditional IPAC measures. They've kept us safe, and they will continue to do so. And public health has been monitoring transmission dynamics throughout the pandemic, And as Patty mentioned, we just haven't seen that in these type of waiting room areas. So I'm confident that this is safe in both in the emerge waiting rooms as well as in our community offices, as long as we follow the guidance that's published most recently. I don't know if people want me to talk about what's changed, but I could if you want.
We'll see what the public that may come up in a live Q&A or for later as well. But thank you, Titus. And thank you, Patty. The next question was number 3, which was on we aren't allowing vaccinated people into unvaccinated people into restaurants, but they are still allowed to visit patients in acute care. Is this true? And if so, what are the risks?
Well, maybe I can answer this just briefly. The vaccine passport requires people to be vaccinated to do certain discretionary activities, such as go to restaurants, movies, gyms, not because these places are high risk. We're not actually seeing COVID transmission in these settings. It's really to create an incentive to improve our vaccination coverage. But we still allow people to continue with essential things like going to the grocery store, going to the pharmacy, going to visit relatives in acute care, going to access healthcare services. And by the way, when those people come to our acute care, they're going to be screened and they're going to be given a medical mask. So, and we're not seeing transmission from visitors. We've seen occasionally visitors to healthcare facilities have been a source of COVID, but they're actually lower risk than staff because they tend to only visit one person, have contact with their relative, and then leave. Whereas healthcare workers who may have had COVID and been in the infectious stage unknowingly might have had contact with many more people. So visitors are actually low risk to introduce virus into a facility. They're screened, they're putting on a mask. So, and again, most of them are going to be vaccinated, but the vaccine passport is for non-essential opportunities, and it's really to create an incentive to get higher vaccination rates.
Great, thank you, Patty. The last question there is, what are the plans for ongoing support of virtual appointments at BCH? So perhaps I'll take this one and start, and anybody can add in as well. But I think, the message, as you've seen, and we've sort of alluded to, is that, the memo that came out combined from Bonnie Henry, Heidi Otter from the college, and Ted Patterson is one of the ADMs in the Ministry of Health, that there's an expectation to get back to in-person care for primary care, community care specialists. But that is not at the saying that then that's at the expense of no virtual care. We know that virtual care was jump-started during the pandemic, and there are a lot of good uses for it. But we also know that it cannot be used for every patient interaction to deliver all types of care. And where we have certainly been seeing pressure points in the system are access points such as we mentioned, the emerge, the urgent primary care centers, the 811 lines, because those provide immediate access, and in the cases of UPCCs and EDs, in-person care. So there is ongoing discussion at multiple tables, I can assure you, of how to make sure that the in-person care continues to increase. As was mentioned in that memo, there's talk about MSP billings, and you've probably heard me say on previous MedStaff forums that when those billing codes were initiated, it was during the pandemic and quickly made to be equivalent, in-person versus virtual. And that's not to say that it was always going to be that way, but that was the easiest way to make it happen right away. And so there's discussion to say, well, what is the equivalent rate and so forth. So that may change as an incentive. I don't know, but those are some of the discussions. We also know that the orders for PPE for community settings, so primary care offices, community specialists, those are also tracked by the ministry. And those, as I understand it, have been increasing, which would support that there is need in those clinics for PPE because patients are being seen in person. So the ways that we are making sure that we try to measure, track the appropriateness, but also the increasing uptake of in-person, getting back to in-person care. Lastly, what I might offer is that at our provincial VP medicine table, we talked about with the college about ensuring that our colleagues are seeing patients in person. And unfortunately, they couldn't offer much more than they are happy to follow up with any physician that may be identified as needing some help or support in getting back to in-person. But that would take somebody identifying them. But they did say that part of their role is to help support that physician or clinician in their supportive in-person care. So there's that avenue as well if need be. In the interest of time, I think we'll move on to the next sections. So Mesh, thank you again for being with us. And I know you usually have phenomenal graphs and data to present to us, so we'll hand it over to you.
Thanks, Chad. So if you go to the next slide, so we've done an introduction, so you can just keep going. These are my disclosures. So I have various local and federal sources for contributing to my salary, and I have had project funding from various vaccine manufacturers before. All funds go to UBC, and I don't have any personal payments to disclose. Next slide, please. So I was asked to talk a little bit about vaccine effectiveness against variants. So I've shown this slide to you before, but just as a brief reminder for anyone who has been trying to ignore the news for the last little while, that we currently have still just 4 official variants of concern, so Alpha, Beta, Gamma, and Delta. And as most people know, that Delta is the predominant strain currently circulating here in Canada, having first been detected in India in December 2020. All of the variants have been associated with increased transmission, some with increased disease severity, and some with reduced serum neutralization. So in vitro antibodies after vaccination are not able to neutralize them, as well as the wild type. And it's mostly minimal impact on vaccine effectiveness, and I'll talk specifically more about the Delta variant since that's the currently circulating one. So on the next slide. So firstly, there's a lot of data, and it's really hard to try and pull it together in a few minutes. So I've stolen some slides that were presented to ACIP, so that's the US body that makes vaccine recommendations, because I think they have really nice ways of trying to summarize a lot of complex data very simply. So first of all, vaccine immunogenicity against variants. And so what this shows is that there is some reduction in the ability of antibodies in the lab to neutralize variants. And I think the caveat to all of this is that we don't yet have a correlate of protection. We don't know how much antibody you need to protect you against infection. So if you sort of go from right to left, the alpha variant, so if there's no effect, then, and so each dot represents a study and the effect that the antibodies have on the variant compared with the wild type. And so the closer it is to the bottom where there's no effect, that means it's basically the same. And then as you go up on a log scale, you get reduction in neutralization. And you can see against the alpha variant, there's minimal impact for most of the studies. The gamma variant, again, probably similar, minimal real impact. The Delta variant we have in the middle, so some studies have shown small impact, some studies have shown a little bit more impact, but actually it's the Beta variant that was causing a lot of concern a little while ago, where there was a lot of reduction in neutralization in vitro. So the Delta variant is there sort of somewhere in between, and the different colors just represent the different types of vaccines. So most of them are dark blue with mRNA vaccines. So next slide shows clinical data then on the actual effectiveness against the Delta variant. And I think just to briefly summarize, in these studies from different countries, including from Canada, there's minimal impact on severe disease outcomes and moderate for infection. So the data from the Alpha variant is in the blue circles and the Delta variant in the red triangles. And in the different countries here, if you look along the bottom, hopefully you can see there's some studies that have just looked at any infection, some studies that have looked at symptomatic infection, and others that have looked at hospitalization or death. And so you can see sort of if you take the UK data, there's a little bit of a difference between Alpha and Delta for infections, and a little bit minimal for symptomatic infections, but almost no difference when you look at hospitalizations. Similarly, in the Canadian data, very, very slight difference in symptomatic infection, but pretty much no difference in hospitalization or death. In the Israel data, there's a significant, huge gap here between the Alpha and Delta for infections and even symptomatic infections, but very little difference in severe infections. And in the Qatar data, for the Pfizer vaccine, there's a big difference in symptomatic infection, very little between for hospitalization and death. And then the far right is some data using the Moderna vaccine. Again, very little difference between hospitalization and death. And I think it's hard to know why, particularly the Israel data looks so different to everywhere else, but let's bear in mind that the Israel program happened very quickly right at the beginning. They adhered very strictly to the 3-week interval from the clinical trials, whereas in Canada, we've had people vaccinated up to 16 weeks between doses, and in the UK, they've been using a 12-week interval, which I'm not saying that's the explanation, but that may be at least partly the explanation. So I think, given that the main goal is to prevent severe disease and death, I think that even with 2 doses of mRNA vaccines, we're still in pretty good shape against the Delta variant. So on the next slide, moving gears a little bit, as most of you will have heard, there's been recommendations for some populations to have a 3rd dose. And again, this is another slide I stole from one of the ACIP meetings. And this shows the response to 2 doses in specific populations. So on this one, where you want people to be as closer to the top. So if you look at healthy controls, that's the dashed line, 95 to 100% vaccine efficacy against COVID-19. And you can see various studies that have been done looking at antibody responses. So again, we're looking at antibody data. There's no real good clinical data on outcomes. So there's some reduction in some studies in people with cancer, hemodialysis patients, mostly up or above 70% or so. In organ transplant, you're getting, some people have very significantly reduced antibody responses, all the way down to some who have no antibody responses related to the medications they're on. And on immunosuppressive therapies, as most of you will know, immunosuppressive therapies covers a whole range of different levels of immune suppression. So probably not surprising to see that a bit of a spread, and some very significantly affected and others not so. So on the next slide, these are the current recommendations, really based on these antibody data. So the national recommendations from NACI are that people with moderate to severe immune compromise should receive a 3-dose primary series. And I think some of the wording is maybe nuanced, and you may think it's just semantics, but it's being referred to as a 3-dose primary series, not as a booster. And that has some implications to the way it's rolled out, but that's what they should receive. So for anyone who's previously completed what was thought to be a complete vaccine series, they should get a dose with any mRNA vaccine with at least 28 days from their last dose. And the other piece that I just wanted to highlight, because it seems to come up a lot in the questions that I receive, is that serological testing is not recommended for decision-making around giving vaccines. And that's mainly goes back to that issue that we don't really have a correlate of protection. We don't know how much antibody you actually need to be protected. On the next slide, just to sort of put a bit of meat on those bones. So this is how it's being rolled out in BC right now. The 3rd dose is being recommended for solid organ transplant recipients, people who are having immunosuppressive therapy for hematological disorders, including leukemia, lymphoma, myeloma, anyone who's on anti-CD20 therapy or other B-cell depleting agents or has been since January 2020, some specific primary immune deficiencies, so deficiencies in T cells, immune dysregulation syndromes, and type 1 interferon defects, and anyone who's had a bone marrow transplant or a hematopoietic stem cell transplant since September 2019 or is still on transplant-related meds. In BC, a preferential recommendation has been given for use of the Moderna vaccine for this dose, although if that's not available, then the Pfizer vaccine is fine. The NACI recommendation does not give a preferential recommendation. There are some data suggesting that the Moderna vaccine is slightly more immunogenic in these settings than the Pfizer vaccine, so that's the reason for that. And as long as the supply is not an issue, then that's the basis for that. But I don't think people should feel they're getting a sort of second-class product if they end up with the Pfizer vaccine in this circumstance. It's there's very little between them. And on the next slide, just the final piece is around vaccination of children. So we have the 2 mRNA vaccines that are approved and being used in Canada for vaccination of adolescents aged 12 to 17 years. And mostly the Pfizer vaccine has been used over the summer, and we've got very high coverage in BC of this population right now. In the adolescents, there's ongoing studies using the Oxford AstraZeneca vaccine, the Janssen vaccine, the Novavax vaccine, all of which have signed pre-licensure agreements with the Canadian government, so may become available at some point in these populations. And then going down the age groups, these trials are going on in the, we should have the data from the 6 to 11-year-olds soon, and then down to 6 months of age. So the data from Pfizer is expected in the last quarter of this year, so very soon. Data from Moderna likely will be the first part of 2022. If we're very lucky, we may get it by the end of this year. And then the Janssen are planning studies down to these lower age groups, but no details yet. And then the last thing I'll just say is that in children under 6 months, they will likely have some protection from antibodies transferred from their mothers if they're immunized during pregnancy, although we see extremely low rates of disease in this age group. But just for completeness, I wanted to add that in there. So I think that was my last slide, and happy to have any questions related to any of that.
Great, thanks, Manish. And a reminder for those who have questions, put them in the Q&A box, and we'll get them into when we do the live Q&A section. We do have some more questions that you did send in ahead of this evening's forum, and so those are going to be the questions that come up next before the live Q&A.
Okay, this next set of questions, are we able to make any predictions on the risk of COVID infections as well as disease severity for vaccinated, unvaccinated individuals and for various demographics based on the empirical data? And what is the planned future status on booster shots or third dose for medical health care workers in BC? If boosters will be given, what's the recommendation for combining these with seasonal vaccinations? And finally, given the current data, when do you think we'll see authorization for COVID-19 vaccine usage in Canada for children who are less than 12 years of age?
Do you want me to start with the first one? Because I mentioned to my fellow panelists that I have data. So we don't need to make predictions. We're actually tracking vaccine effectiveness here in BC, and we report on, for all the cases of COVID-19, their vaccination status, and BC CDC is monitoring this. And we know that based on the latest data, that your risk of becoming infected with COVID, with the current surge in cases we've seen with the Delta variant, is 11 times higher if you're unvaccinated compared to people who are vaccinated. But your risk of hospitalization, there's an even bigger difference. It's more than 60 times higher for unvaccinated people. And your risk of death is 25 times higher. So the fourth wave we're seeing is primarily driven by unvaccinated people. They're at far greater risk of infection. And we do get cases among people who are vaccinated. You know that even with the initial studies of the mRNA vaccines, they were 95% efficacious, not 100%. And Manish showed you the data, a reminder for the Delta variant, they're a little bit, the effectiveness against infection is a little bit lower, but still very good. So there will be people, and we do have people who are fully vaccinated who become infected. They're at much lower risk of severe disease, but we're not seeing any evidence of waning immunity. We're not seeing that those cases among vaccinated people are being seen more in people who are vaccinated early on in the first part of our vaccination campaign. It seems to be consistent. And in fact, the people who are vaccinated that are more likely that we're seeing infections are the same groups for whom we're seeing more cases of COVID right now, which is young adults, because they have more social interactions and they've actually been more recently vaccinated. So in other words, the data here is quite clear in BC that your risk of infection is far greater if you're not vaccinated, and your risk of severe disease, there's an even bigger differential. That's what's driving the increase in cases and the increase in hospitalizations. And I think Manish dealt with the boosters. He's shown you the list of who we recommended a booster. There's no recommendation at this point for a booster dose for healthcare workers. I just was on the Providence MAC last night. I said don't, and I don't anticipate there'll be any such recommendation this fall. And I think you've talked about the children, Manish, as well, where we are. I would just say for kids, there are trials underway. In order to, there's a two-step process for a vaccine to be licensed for kids. Data will have to be presented to Health Canada. They're responsible for licensure, but recommendations for use of the vaccine would come from the National Advisory Committee on Immunization. And even if a vaccine is licensed for children, they will, there'll be a number of considerations that they will look at before any recommendation is made, including the risk of severe disease, which is very low in children, the risk of side effects from the vaccine, and perhaps the role children might play in any ongoing community transmission of COVID if they're exposing other people who are at higher risk. So I don't know if you have any comments, Manish, but having a vaccine license for kids doesn't mean there'll be a recommendation to use it for kids.
Yeah, no, and I think you said it all there, Patty. And I think it's important that NACI has a pretty standardized framework for considering all of these, considering the ethical implications and considering the overall impacts of vaccinating or not vaccinating in this population. So I think we'll have to see how those recommendations play out. I think in terms of timing, up to now, it's been relatively quick in terms of once Health Canada give approval, NACI making a recommendation. So I would expect, again, this is already something that people are thinking about, but until we see the data, it's hard to make those decisions. And I think that if and when it comes, it will come a little bit sort of bit by bit. So I think, as I said, the way the trials are being done, we'll have the data on the 6 to 11-year-olds first. Then we'll have the data probably on the sort of 2 to 5-year-olds, and then the 6 months to under 2-year-olds. So the data will come in that way, and so the program will be rolled out in that sort of way as well.
Great, thank you for that. I do have a couple of follow-up questions, Patty and Manesh. It's from questions I've heard, I think from at different tables, and I think from some of our med staff. One being, if there is somebody who's eligible for their 3rd dose in that primary series, how are they going to be notified? And then the second question is, it just slipped me. So why don't we go with that first one, and I'll see if I can remember that second one. But the notification if you're for your 3rd dose.
Yeah, this you will be contacted directly. So as with the previous program for clinically extremely vulnerable, this is being rolled out through the PHSA. They are going to be, I think there's about 15,000 people in those groups that Manish mentioned. They're going to be notified. There will be a process, as there was last time. If physicians have a patient who they believe is in one of those groups and they don't get notified, that they can fill out an attestation form. That's not going to be available until September 17th, and will be on the Doctors of BC website. So, yeah.
Great, thank you.
And I think the other piece about sort of it not being called a booster dose is that for any reason, if there's people in those groups who haven't received any doses, so then they will essentially start from scratch and get a 3-dose primary series. So for people who've already had 2 doses, they'll get a 3rd, but yeah, everyone else will, I'm sure there's not that many, but yeah, that's how it would be rolled out.
Great, thank you. Yeah, and I remember that the other question was for those children that are turning 12 in 2022, will they only be eligible for the vaccine on the date of their birthday going forward, or is it from perhaps like January 1st of 2022?
No, we've been one of the provinces, and not every province did this. Ontario just did it, where we've allowed children to be eligible the year that they turn 12. So for everyone who's turning 12 in 2021, they've been eligible, even if their birthday has not come up yet. So the birthday might not be till October, November, December. We made a decision, a public health recommendation, to give it the year you turn 12. So we are planning, regardless of the studies that Manish is doing and what may come with the younger kids, that on January 1st, there's going to be another cohort of children who are going to be eligible for vaccination because they're turning 12 in 2022. And we will vaccinate them likely through school-based campaigns as early as possible in 2022. They won't have to wait for their birthday.
Great, thank you so much. Okay, so now I think we will move on to the live Q&A part. So those will be the questions. Oh, we have a couple more questions. Sorry about that. I'm jumping ahead.
Okay. So this quick question is on policies to guide practice for Patty. Will mandatory vaccinations be required for healthcare workers performing direct patient care? And if so, when is this set to occur?
So I think you've probably seen the announcement from Dr. Bonnie Henry this week. The question probably came in before now. As you know, there is an order that requires staff working in long-term care, assisted living, and provincial mental health facilities to be vaccinated by October 12th. That is being implemented right now. Announced, I believe, on Monday, is that the mandatory vaccinations will apply for healthcare workers in acute and community settings. The details we're waiting for. The date is a bit later. It's October 26th. So stay tuned. When we get the written order, we'll share those details. One of the reasons why I think there's 2 reasons why we're doing this. One is there was concern that if it's mandatory only in long-term care, staff will leave long-term care and work in other settings. And secondly, this is being done because of risk. And the risk is not only in long-term care settings. We've seen outbreaks occur in acute care. We've seen transmission from staff to clients in home care, home support programs. So the risk exists in other healthcare settings. So it will be expanded, but we're waiting for further details on the provincial health officer's order for those other settings.
Great, thank you, Patty.
Okay, and just the last few questions on IPC. What are the ongoing benefits of the PPE measures, such as masks? I'm wondering what to do about unvaccinated patients who need to be seen in person and refuse to wear a mask. And what is the status of being able to use nebulizers in long-term care homes?
It definitely, we'll tag team this like everything else, Patty. So I think we recognize that some of the measures that were put in place early on during the pandemic, I'm looking at the March 2020 PPE allocation framework, where they put in place the mandatory universal medical mask, mandatory eye protection, mandatory gloves. Similar to what Patty was talking about with the physical distancing, this was during a time where we didn't know as much. We didn't have the vaccine, and now we're in a much better place. We're now stepping back from all of those mandatory eye protection and gloves. We have continued with the mask, but the eye protection and the gloves, please perform your point of care risk assessment, just like you did prior to COVID. And if it makes sense, please use your eye protection, use your gloves. Otherwise, it's no longer necessary. The ongoing benefits, we have to remember that while we enjoyed a very low, record low influenza season last year, that's not promised to be the same in the fall. I mean, it's I can't predict, but we can't rule it out. And so we have to look at this from a more syndromic approach. This, just because it's not COVID, it doesn't mean it's not influenza. It doesn't mean it's not RSV. We saw enteroviruses, other viruses make a bit of a comeback this year. Anyway, so that's just to say, like, there are other things that cause influenza-like illness, not just COVID. The second thing, I wonder what to do about unvaccinated patients who need to be seen in person and refuse to wear a mask. Again, remember that, Patty and Manish has said this, the vaccines are very effective. They're not perfect, but they're really, really good. And so you yourself, if you're vaccinated, combined with you in PPE, is going to be protective. It doesn't matter what the patient is wearing, you are protected. And I think as long as, I think that served us well before COVID. And so I don't want anyone to feel as if they are somehow unprotected or more at risk if your patient doesn't wear PPE, okay? I don't know if Patty or management.
Well, I would just say, see the patient and provide the care they need. That you have an ethical responsibility. There are people who in long-term care, we're not making the residents put on masks. The staff are providing care. Tad works in the emerge. He has to look in people's mouths. They can't always wear a mask in hospital. We don't make patients wear a mask in their room. So provide them care. That's what I would say. And don't get into confrontations with people. And I say the same, by the way. And people have to wear a mask when they go into indoor public settings now, grocery stores, other places. And don't get into a confrontation with people, is what I would say to staff if they're not wearing a mask.
Yeah, that's a really good message. Thanks, Patty. And regarding nebulizer long-term care, so you remember that one of the things that we were committed to doing provincially is to evaluate the evidence on an ongoing basis, including what are some aerosol generating medical procedures. We found that some of the nebulizers, especially using vaporizers, were aerosol generating. And so we had recommended that if your patient is suspected of having COVID or confirmed to have COVID, that please, unless you have a negative pressure room, please find an alternative way of delivering the medication, such as with an MDI. Now, if your patient is not suspected of having COVID, is not confirmed to have COVID, or is COVID negative, then certainly nebulize away because that's not a risk. I do have to contextualize that a little bit more, because if they have been suspected to or confirmed to have another ILI, that's also something you might want to avoid.
Thanks, Patty. So I agree. In the emerge, I think it's more common now than before, but it usually, during the respiratory season and the flu season, we would tend to stay away from nebulized if we could all help it, and use MDI puffers. And so I think it's become very common practice now, because so long as you can use perhaps even an aero chamber when the patient's alert and can do part of it, then it's still very effective. So I agree with you. It's contextual, but also I think it's more common practice now that if it's something that we can do and the patient is amenable to it and can use perhaps this space for something, that it's very effective to use MDIs over nebulizers. Okay, I think we will go to the live Q&A portion for the last sort of 10, 15 minutes that we have. And so a reminder to those, put your questions in the Q&A box, and we will bring them forward and try and get them answered. A reminder as well that those that we don't get to, it will be archived on the MedStaff intranet. That was one of the earlier slides. And this whole MedStaff forum being recorded will be archived there, so you can always go back and take a look, or if others want to as well. Thanks.
Okay, the first question, could the panel elaborate on breakthrough infections in fully vaccinated individuals? What percentage of asymptomatic vaccinated people are capable of spreading the virus? And how does this change over time with duration of time spent after the vaccination?
Well, I think I answered that question in terms of, we're monitoring effectiveness of the vaccine and the likelihood of infection for vaccinated versus unvaccinated. I will say that we do have vaccinated people who acquire COVID can transmit the virus to others. We've seen that here, even in our follow-up of cases here in BC, but they appear to be at lower risk of transmitting the virus to others. So they're less likely to transmit than someone who acquires COVID who's unvaccinated. But the data that we're seeing here is not indicating waning immunity, as I think I mentioned. It does indicate that people who are fully vaccinated can become infected. They're at much lower risk than those who are unvaccinated, and they're certainly at much, much lower risk of hospitalization and severe disease.
Thanks, Patty.
Okay, next question. I am a pregnant healthcare worker who's concerned about the October mandatory vaccination requirements. It seems too soon to include us in this requirement with the limited data regarding the safety of vaccinations during pregnancy, according to trimester, and the safety of vaccinations of younger children. What are my options?
Manish, I don't know if you want to answer that. I will say it's I'm a little concerned about pregnant women that may not be aware that the recommendation now is that you should be vaccinated. So when the vaccines were first licensed, the trials were not done on pregnant women, and the recommendation was the decision to vaccinate should be based on a recommendation of a healthcare provider. We recommended with those first healthcare workers we vaccinated, all pregnant women get vaccinated because we knew that their risk of COVID was much greater than any risk from the vaccine. That recommendation has actually now changed because of data that shows pregnant women are at higher risk of severe COVID compared to women who are not pregnant, very similar to influenza. So we recommend that you as a healthcare worker should, or who are pregnant, should get vaccinated. You will not be exempt from the mandate. There will be an exemption process for the mandatory vaccination for healthcare workers. It's going to be based on people who have a true medical contraindication to all available vaccines, mRNA vaccines and AstraZeneca, and it's going to be very, very few people. These are incredibly safe vaccines, but Manish, I don't know if you want to address the pregnant women as well.
Yeah, I mean, I think Patty's addressed the part of the question about the options, and I think in terms of safety, I would completely agree. So I think, we've seen from multiple studies, including a large national Canadian study, that people who are pregnant are at higher risk of those severe complications compared with age-matched non-pregnant individuals. And we've got now accumulating data around the safety of these vaccines in pregnancy. They are safe. They are not associated with increased adverse events, either sort of the typical vaccine-related adverse events or increase in adverse pregnancy outcomes. And so there's definite recommendations in Canada, in the US, in Europe, across many, many countries that people who are pregnant should be vaccinated.
Great, thank you.
Next question. What is the risk of new variants, i.e. mu, that are resistant to the current vaccines?
So the risk, sorry, I don't think I quite caught some of the question.
I'm sorry.
They're asking whether or not the mu variant would be a concern, will escape protection from vaccines.
Got it. So I think that we don't know. As answer to this is, is the new, as far as the last time I saw, this is still a variant of interest rather than a variant of concern. So, we don't know. I think the important thing to remember, though, is that the vaccines contain the spike protein. It's not just one part of the spike protein that is the target for protective antibodies. So even if you had a mutation in some parts of the spike protein, there are other parts of that protein that could be attacked by vaccine-induced antibodies. So I think while it's certainly possible that you'll get some escape from vaccination, we've seen that, the beta variant, we did see with some of the vaccines that there was reduced vaccine efficacy. So it's certainly possible, but I think that we'll just have to wait and see. And, sort of without trying to sound like a broken record, I think I'll go back to what Patty's been saying, is that we have real-time ongoing surveillance of vaccine effectiveness in BC. And I think if we see waning or if we see variant breakthrough, then we will see it quickly. And I think we'll know, and then we'll be able to, try and do something about it, whatever that is. But so I think that I don't know the answer, but I would hope not, but yeah, can't give any guarantees.
Thank you.
Okay, next question. Can unvaccinated healthcare workers who only do virtual health keep doing that, unvaccinated, if they don't see patients and they wear a mask when they're in the hospital?
We don't have the written order yet for the vaccine mandate for acute care. So when we get those details, we'll let you know. I think you need to assume that if you're working in a clinical setting, the mandate is likely to apply to you. If you have questions or concerns about being vaccinated, we're here to address those. We want to hear your questions or concerns. These are safe and effective vaccines. But once we have the details of the public health order, it's not actually published or written yet, we will certainly make sure that it's made available to you, as we did with the long-term care order.
Thanks, Patty. And I guess I would add to that, maybe I heard the question wrong, so Lori, correct me if I'm wrong, but the question was, if the provider only does virtual care, do they need to be vaccinated if they're visit a patient on site?
Can they keep doing it if they're doing just mostly vaccine?
Right, but I guess the reason I'm wondering is if you're doing purely virtual care and you have no patient interaction and you're not on a clinical setting, I guess that's one thing. But really, I guess it gets to the point of if your practice is exclusively virtual care, there might be issues with that, in the sense that I can't imagine there'd be a patient or patients that you won't at some point need to examine in person and have that clinical interaction, and then likely in a clinical setting. And so, which would be, necessitating vaccination. It did strike me that the college has put forth, I believe, a timeline with which if you do virtual care and it's only virtual care, I think will allow you to hold your license for a total of a maximum of 3 years. If you plan to do exclusively virtual care past that, they will no longer license you as a provider. So that's something to be aware of, I think. And sorry, it just struck me as I was thinking down that path. So the idea being that your virtual care, in some settings that may be the majority of what you do, but there will always need to be an in-person component, and perhaps for each individual patient, there'll be the need to have you available as a provider for in-person care if needed. Sorry, I think I went in a bit of a tangent on that, but the question sort of struck me that way. Thanks.
Okay, next question. Can you provide an update on travel and international recognition of vaccines? Will it be an issue for those of us who have received mix and match?
This is a challenging question, because in Canada we did, based on recommendations of experts, and and Manish and I were on this panel saying, take the first vaccine available to you. There are people, who took AstraZeneca, then got an mRNA vaccine, got one mRNA vaccine, went back for their second, and a different one was available. I can tell you that a large number of my own family have 2 different vaccine doses. And we relied on the federal government to work out agreements with other countries to accept our vaccination schedule, and that has not happened yet. I can tell you, to be upfront, that those of us who work in public health have recommended to the province that there are certain people who must travel for essential reasons, essential work, compassionate reasons, perhaps to visit a dying family member in hospital in another country. And because that country won't accept a mixed schedule, they might be forced to quarantine, and that could be create significant issues for them. We have recommended that there be an option for a third dose, but so far that's not been approved. So it's something that you may want to advocate on behalf if you have patients in this situation. I would certainly encourage you to advocate on their behalf to the Ministry of Health. Ultimately, it will be the federal government and all countries that will have to get, we do the same here. We only accept vaccines that we've licensed here in Canada, and we make everyone else quarantine. So ultimately, you know, hopefully through the WHO will resolve this, but in the interim, I would encourage you to certainly advocate on behalf of any patients where this has become an issue.
Thanks, Ross. Hey, I wonder, can I just go back to that other question around the mandated vaccines for physicians, healthcare workers in all facilities? Because what I wondered about that is the question, or a part of that question, if I'm not doing virtual care, may I still come into the hospital masked and see a patient? And I think there's another important part that the order, I'm sure, will clarify, but it was put in the description, which is, you know, that if you work and you have privileges in a health authority, you're mandated to have that vaccine. If you're strictly in a private office, then you don't need that vaccine. That's your choice. So that's kind of an important distinction, because of course privileges, in order to come to a hospital as a physician and to practice medicine in the hospital, you need privileges to do that. And those privileges will be, I'm sure, linked, I can anticipate, will be linked to having that vaccine in order to comply with the order. So we will hear more. For sure, the order will clarify that. But I think that's an important distinction. I suppose if you are practicing in your office purely virtual and are not vaccinated, and you come to a hospital to visit somebody but not practice medicine, that's the difference between I'm coming in with an ID, I have privileges, I'm going to look at a chart, I'm going to make an entry. You're practicing medicine, you can expect, I suspect that you will expect to be, we will expect you to be vaccinated.
I think you're right, Ross. We have also heard that you know, the healthcare practitioners who work only in their private office, they don't go into an acute care, they don't work for, you know, provide community care in a health authority community care setting. It probably won't apply to them. But yeah, if the question was that you want to go visit your patient in hospital as their healthcare provider, Chad and Ross, I think you're right. But if you're going in to visit your family member as just a family member, it would be different.
Great, thank you. We have one last question and then we'll wrap it up.
Okay, when will the visiting restrictions change for our mental health patients? 1 hour a day and one visitor is not in this population's best interest.
Got it. I think we probably should tag team this one. So I think for acute care, August 31st, there's some new guidance for acute care visitors. They've changed it such that there's no more essential or social visits. They're just visits. You can have 2 visitors at a time, unless in critical care or emerge, they might limit to 1. You know, remember that, you know, I agree that the you know, the mental well-being of our clients and patients are essential. And I think that this was always the case. And if it was important for the mental well-being of the patients, then absolutely you could have visitors. And I don't think there's any 1 hour. I'd recommend that if you're having some restrictions at your particular site, maybe due to some outdated guidance, reach out to either your public health, IPAC, or your people safety rep, and we'll help you rectify that. Thanks.
Yeah, I would say that some places may not be aware of the new changes in visitor guidance. We had this in long-term care too when they changed it. So if there's an issue, just bring it to your site lead and they can make sure with Titus's team that they're following the updated guidance.
Great. Thanks, Patty and Titus. Okay, we're ran a bit over. I apologize for those who have joined us, but we certainly wanted to get to as many questions as we could. And again, for those that we didn't, we will archive them, find answers and archive them and put them in the REALC bulletin, as you'll notice that we tend to include some questions every time. Next MedStaff Forum will be October 20th, so you can register with that link. Emails will go out. If you have some feedback on what you'd like to see in the next MedStaff Forums, certainly put it in when you register and or the feedback in that survey there. sort of a final thought for me is that, a lot of what struck me today from the conversation, really good questions and comments, certainly from our panelists, as always, is the importance of context, and that it's exhausting how the context keeps changing. And yet we're doing well in keeping up with our responses to the existing context. And that could be from PPE to the capacity of waiting rooms, as we talked about, to the real-time surveillance of vaccine effectiveness. And we're using all of this in building policies and direction as best we can. And yet, as changes come out, it's always hard to know when to turn on a dime sometimes. So what I'd say with that is that I think a lot of us know we're all doing great work, but we're tired. And I think it's okay to acknowledge that. And you've heard me say this before, but I think it is important that we still remain compassionate to others, of course, and patients and our colleagues, but ourselves as well. And one of those things, again, if you need help, reach out for it. And again, just let it be okay that you're tired, because we all are. And we'll, again, continue to inform you as best we can through all the ways that we have been doing with med staff forums and town halls and REOC bulletins and small groups and so forth. But I do wish everyone well. Take care, get some rest, and we'll see you soon, but October at the next med staff forum as well. So thanks for our panelists and to yourselves.